Hello, everyone. Welcome. Just take a few minutes here while people get signed on. Feel free to introduce yourself there in the chat. Sunita, if you can allow the chat, that would be great. Thanks. Well, welcome, everyone. Just be a couple minutes here and then we'll get started. Thanks for being with us tonight. Hi, Lisa. Welcome. Hey, Kevin. Welcome. So just quickly, I'll do a little bit of an intro and then we'll get right into it. So welcome to our Victoria South Island LTCI Learning Series event on addictions. Please feel free to introduce yourself into the chat or unmute and say hi. I'm Jessica, the Victoria South Island LTCI Program Manager. I'd like to take a moment just to welcome you to our LTCI Learning Series event this evening. It is with great respect and appreciation that I am speaking to you on this gray and misty day from the traditional and ancestral territories of the Sauk Nation, where I'm very lucky to work and live. So just a couple of housekeeping items first. This is a CME event, so a certificate will be mailed to you within the week. There will be an evaluation at the end, so please take a moment to complete it as your feedback is very important to us. The event today will be recorded and placed on our website, so please refer your colleagues if they might be interested in watching. You will notice two documents in the chat that Steve will be popping in there soon. There is a sessional funding available for our 2 accredited programs with the BC Centre on Substance Use, so please have a look and apply if you're interested. This will be related to what we're talking about tonight. So in no particular order, I'll introduce our presenters for this evening. We've got Dr. Chris Stuart. Dr. Stuart graduated medical school in 2017 from UBC's Southern Medical Program in Kelowna, where he became interested in underserved populations and addictions. His residency finished in 2019, focused on a combination of acute inpatient medicine and inner city addictions medicine. Since residency, he has come back to Victoria and he works at Kool-Aid. Hi there. Oh, he works at Kool-Aid as a hospitalist, as one of the physicians at Safer Victoria, and is the primary care lead for downtown Victoria. So lastly, but not least, Dr. Stuart is the MRP for the Summit Specialized Populations Unit, a long-term care unit dedicated to individuals who are difficult to manage on a typical LTC ward due to more severe and active substance use disorder and or mental health. So next up, we have Dr. Alicia Pawluk. Dr. Pawluk is a family physician practicing in Victoria with special interests in care of the elderly, emergency medicine, and addictions medicine. She has a specialty training in family medicine, care of the elderly at the University of British Columbia, and integrative medicine at the University of Arizona. Dr. Pawluk is an assistant professor at the University of British Columbia and a UBC Director of Community Geriatrics. And last but not least, we've got Dr. Chris Blashko with us here today. Dr. Blashko is a psychiatrist in Victoria. His practice prioritizes comprehensive patient education, ensuring individuals fully comprehend their health status. He specializes in addressing patients afflicted by acute or chronic mental health conditions. His overarching aim is to alleviate patients' distress and enhance their coping abilities. Dr. Blashko works along Dr. Chris Stuart at the Summit Specialized Population Unit. So without further ado, I will pass it over to our great presenters for this evening. Thank you.
Well, we didn't rehearse this, so there may be some challenges and everything. So I am maybe we'll talk a little bit about how this evening's going to progress, and I'm going to ask Chris Stewart to do that for the most part. But I wanted to thank everybody for attending today. This is a really interesting series that we're hoping to work towards over the course of time. To talk about the specific area of addictions in long-term care, which is really a very interesting and I would say a black hole of information kind of area. So what we're hoping to bring is multiple perspectives, both Dr. Stewart's, Dr. Pawluk's, and my own, to this group, as well as provide some feedback and hopefully some practical ideas about how to address these within your sites. And most of this presentation today, I think Chris is going to be presenting. My role, I'm sort of I'm here really as a support to my colleagues. They're the addiction experts. Though I'm a psychiatrist, our addictions training during the 90s and early 2000s was a fraction of what we really know today. And so I think in terms of new information and approaches, I really will rely on Alicia and Chris. So Chris, can I just hand it over to you to get started?
Thank you, Chris. This is going to be fun. Okay. First off, thank you everyone for coming. This is a bigger turnout than I think we were expecting, and is really wonderful to see so many people here. And I'll start off with my land acknowledgement as well. So I'm blessed to come to you from the traditional occupied, stolen and unceded territories of the Lekwungen speaking people of the Bosanek, Songhees, and Esquimalt First Nations. And as we go through this talk, future talks, I think it's important for all of us to hold in our heads and in our hearts the fact that our Indigenous patients have a disproportionate negative health outcomes, especially in the scenario of addictions. And we're also talking about a fundamentally colonial system where people are, housed and in hierarchies. So keeping that in the back of our head at all times, and especially also we're caring for our elders and the importance of elders and knowledge keepers in Indigenous and also all societies. And so those are the folks that we're talking about caring for. So just love it if we could all keep that in mind as we go through this. And as it got brought up to do this learning series, Chris Blashko, Alicia, and we talked about it, and we realized addictions in long-term care is a really big topic. It's not something that we could just do in a quick 1 hour, hour and a half session. And so when we were talking about it, we figured doing a learning series where today in the first visit, we would talk about the state of the union, so to speak. What's the evidence? What's going on in addictions and long-term care? What trends are we seeing? General approach to long-term care addictions, and some brief resources to help arm individuals with the right tools and education to treat these patients, but then also have ongoing discussion and ongoing learning series. So I think there's already another lecture booked for February on alcohol use disorder, which would probably be the most, or certainly is the most common substance use disorder seen in long-term care, and follow-up sessions on, and this is where you guys are going to be really useful to us. What do you think we need to hear about? I think opioids, considering we're at the epicenter of the opioid epidemic here in BC, but what do you think that we need to talk about? Like I said, I think alcohol first, opioids second, and then going into other ones, nicotine, benzos, cannabinoids, other stuff. But from all of you, we would love to get your thoughts about that. So without much further ado, I'm going to try and share my screen and present. There we go. Okay, now I want to see if I can get a presenter view going on here. My apologies for this being a little bit clunky.
We can't actually see.
1 second. Okay, so it looks like you guys can't see my screen, so 1 second. That work? No? Okay. I'm sorry. We probably should have rehearsed this beforehand. Let me see if I can. I have started screen sharing, but
That doesn't work. You could also email it to one of us and we can do it.
yeah,
It's weird though, because
sorry.
it's showing on our side that you started screen sharing, but then it's showing just black.
Okay, real quick. Who should I send the presentation to?
Yeah.
Or me, why don't I just put it up?
Sorry, what's that?
Why don't I just put it up on my screen?
Okay, Alicia's gonna try and do it on her screen and see if that works. 1 second. Sorry, folks. Yeah, okay, I guess that works. Okay, so addressing long-term substance use in long-term care, hopefully a comprehensive approach. So none of us really have any disclosures. Yeah, that's about that. We wish we did. So Alicia set up something called Slido. If you want, you can put your questions into the chat for Zoom, but if you use your phone to scan the QR code here, first off, there's a couple of questions that are a little bit interactive, and it would be nice to see if folks could try and be involved in the presentation. And also you can use Slido's Q&A function to ask questions as we go along. Ideally, we would like if you could keep your questions until the end of the presentation. Hopefully the presentation will be about 60 minutes long or so, which should leave us about 30 minutes for questions at the end. That being said, it can be difficult to remember your questions. So if you just either put them in the chat at Slido or in the chat here on Zoom, that would be great. So hopefully I've given you enough time to join the join the Slido thing here. Yeah, okay, we're good.
The link is in the chat. The link is in the chat.
And the link is in the chat. Okay. So next slide. Yeah, can you guys tell me just off the get-go? You're obviously here, but how confident are you about managing addictions patients in long-term care? See if anybody. Oh, there were people who have actually done the Slido thing. Yay, thank you. Okay, so far we have a fairly reasonable spread. We have definitely a predisposition towards the less confident. You have some very confident folks, which thank you. And it's really nice to see that we have some people here that are fairly confident in this. And as you will notice as we go through, the moral of the story is today there's extremely little evidence here, great positive evidence. So anybody's personal experience would be greatly appreciated. That's really what we're giving you, along with a bit of a literature review. So yeah, if you are the quite confident folks, please let us, give us some of your insights. And sorry, just a bit of a hiccup in presenting here. Let's see if this works. Okay, nice. Okay, so moving on. Maybe not. Maybe. Yeah. We can probably do this at the end instead of getting you guys putting your questions here, I think. So yeah, yeah. Okay, so sorry. Order of things for today. So we're going to go into the current situation about substance use in long-term care, go through some of the epidemiology, what's known about what's going on, what are the general trends, some specific issues in treating substance use disorder in long-term care, some basic principles of substance use management, a brief general approach to substance use disorders, again, some brief resources, and then hopefully time for some good discussion at the end. And then next time, again, specific talks, alcohol, then opioids, and then what? And you guys can let us know what you feel like you need. So it's no great surprise to anybody working in long-term care that Canada's population is aging. The over 75 age group is going to double, and over the next 20 or so years, we're going to get a much larger number of individuals needing long-term care levels of care. And even if substance use disorder rates stayed the same, the absolute number of individuals with substance use disorders is going to grow because in long-term care at least, because the long-term care population is going to grow. So we are going to be seeing a larger population in this age group. We're going to be seeing a larger number of individuals with substance use disorder. And we have a couple of different phenomena happening all at the same time. We have, as I said, the overall aging population. And really interestingly, so the aging population is the baby boomer population. And in the literature, it's pretty clear that the baby boomer population was the first population to really be exposed to recreational drugs, whether it was cocaine or LSD or heroin in the 60s, 70s, 80s. That population, compared to the greatest generation and previous generations, they really have had significant exposure to substance use, including polysubstance use. So that population is aging. We also have a concurrent, highly toxic, unregulated drug supply that is resulting in individuals requiring long-term care due to sequelae from that at a much younger age. So the intersection where these both meet is where we're all at and what we've all seen, which is we have a larger number of individuals who use substances, but also need a higher level of care. And part of what I really want to acknowledge here is that I know care providers in long-term care settings are really noticing this, and this is largely just validating what you and I are all seeing. It's very real. So long-term care populations are changing. The number of less than 65-year-old individuals in long-term care is growing. In the US, the rates have increased. It's a little bit old data, but from 24 to 2011, there was a 3% increase in that time, and that is continuing to increase. There just isn't a lot of data as to the specific numbers. Island Health specifically has about 19% of the people in long-term care are under the age of 75, and in the South Island, a little bit higher percentage, 21% of those individuals in long-term care are less than 75 years old. That's a really high proportion of people. And a large number of those individuals have comorbid psychiatric or mood disorders as well. Going along with that, alcohol and prescription drug abuse affects quite a lot of individuals over the age of 60. It's not just a phenomenon of the younger individual. So about 17% of people over the age of 60 use or misuse alcohol and prescription drugs. There is like I said, a paucity of information on this, but from the United States, which is this 2019 study, about 10 to 11% of individuals over the age of 65 engaged in binge drinking in the last month. And if you looked at in the last year, that number is quite a lot higher. In Canada, unfortunately, we don't have too much data here, but daily drinking in the 65 to 74 age group is about 3 times higher than that younger age group. So that older age group is at high risk for having either high risk or substance use disorders. And there's very little data about cannabinoids, other substances, and that kind of stuff. And I do want to point out that, unfortunately, the diagnostic criteria used to diagnose substance use disorder, so your DSM-5 criteria, often is not relevant in that older population. We'll get into that a little bit in the future. So this is not an opioid talk, but there is a really fantastic group here in Victoria called Substance, and they work with University of Victoria to do mass spectrometry on samples of substances that individuals have bought and plan to consume, and they see what's in those substances. And the main reason why I'm showing this slide, and I know it's busy and we're not going to look at all of it, but it's really to show these individuals who brought in these substances specifically are expecting opioids. If we think that they're expecting heroin, well, they're going to be sadly mistaken. Of the 224 samples that were brought in, only about 17 of those were actually heroin. The vast majority were fentanyl, and the vast majority of those were adulterated with some other kind of substance. Victoria is this line, this column called substance. It's kind of confusing, but what I want to bring your attention to here is the adulterants, including bromazolam, etizolam, other weird designer benzodiazepines, xylazine, which is a sedative hypnotic used in veterinary medicine. There's a phenomenal amount of adulterants in the street supply right now. You don't need to get into the weeds, but it's toxic, and it's highly toxic. And of course, we in BC are in the absolute epicenter of what's going on in this scenario. This is data from the first half of 2023. We don't have data from the second half, but darker means worser. And as you can see, BC has the highest number of overdose death rates in Canada by quite a large margin. And year on year, that number just keeps on going up. So we really are in the thick of it here. Government of Canada has some interesting plots here. They get fairly busy. We're just looking at the bar to the farthest most right in each of these plot graphs, the over 60 crowd. Unfortunately, they don't break down the age any further than that. What I want to show here is that older individuals greater than 60 years old are still fairly well represented in opioid, and the next slide will be stimulant-related harms. About 10% of all opioid-related deaths are in the over 60 crowd, but the vast majority of the opioid-related hospitalizations are in that over 60 crowd. So older individuals are very well represented in opioid harms. And this is just to point out that older individuals do use quote unquote harder drugs, including fentanyl, fentanyl analogs, and other non-fentanyl opioids. And it's a fairly similar but steeper slope with an increase with related to stimulants. So we are seeing more and more of the over 60 crowd using stimulants, resulting in deaths and hospitalizations. And the next slide just shows that, again, those older individuals, they are still using things like cocaine, crystal meth, other stimulants as well. So just taking a bit of a step back and looking at where we're at so far with a brief summary. So number one, baby boomers are more likely to use substances than prior generations. Thankfully, they're also more likely to seek help, which is great. But that also means that we're more likely to get asked about substance use in this generation. There is a very concerningly increasing toxic, unregulated drug supply. We are the epicenter of the opioid crisis in Canada. We are the cutting edge here. Older patients are well represented in substance use related harms, and we have this growing population of under 75-year-olds in long-term care. So this is where we do all the caveats. Other than what I just presented to you, there is a severe lack of evidence base in this population. Substance use is very underreported. It is very undertreated. As noted before, the standard diagnostic criteria that we use from a DSM perspective is often not always applicable in this age group. Your ability to not function at school and at work and other related things. These individuals are often more socially isolated, so the social impacts are different. So the diagnostic criteria is difficult. And we also see this with the more street entrenched population, but there's very much a chronologic versus physiologic age. But we definitely see it in our long-term substance users as well. So we have people who might be substantially younger than 75, but be physiologically 85, for example. So, okay, getting into this. So substance use among older adults puts additional stress on very vulnerable body systems. It reduces our ability to deal with consequences of the aging process. That's the bottom line of what we're dealing with here. And substance use is a spectrum. So instead of thinking about it in rigid criteria, we like to try and think about it as some people don't use substances, some people have a major addiction, and then there is a wide variety in between. Some things that are major precipitants for either starting or escalating substance use include major life events, such as the loss of meaningful employment, the loss of freedom and autonomy, the loss of physical abilities, social isolation, and the loss of loved ones. All of these are things that happen as we age, but a lot of them are also things that happen as we transition into long-term care. So as somebody who moves into long-term care because of a loss of physical ability, they then become socially isolated. They have lost some of their freedom and autonomy. And all of these things are triggers for either increasing their substance use or developing a new onset substance use disorder. So it's very important to continue having this in the back of your head. And as people use substances, they have a lot of negative health outcomes. They can have negative physical health outcomes. Their mental health can get worse. They certainly have a decreased ability to care for themselves. It can cause family strain, social strain, often a lot of isolation. Obviously, there's legal problems. A very challenging thing, and we'll get into this later, but there will be changes to capacity over time. And then, of course, there's always death from alcohol and substance-related comorbidities and overdose. I don't really need to tell all you guys that. You know most of this, but validating and confirming. So as individuals age, and again, we all know this, but just to reiterate, their systems are more vulnerable to the toxic physical effects of substances. People are often hospitalized due to the adverse effects of their substance use, whether that's from cardiac issues, renal issues, liver issues, the whole shebang. And there's a markedly higher mortality in frail adults with substance use disorders. And I want to highlight the use of the word frail there. So frailty is an important concept that we haven't really defined, but frailty can be related to age. It can also be related to medical comorbidities, multi-morbid individuals. Frailty is a larger picture that we need to view our patients in. And our patients certainly have a disproportionate social consequence, whether that's homelessness or legal issues, as we mentioned before. We also know, and this ties into the last slide, that there is a very strong association between people who use substances and having falls, other accidents, cognitive impairment, and we mentioned capacity being a major issue before. I know Dr. Blashko is keenly aware of the overlap between depression, suicide, other major mental health disorders, and substance use, and how substance use causes mental health disorders, but mental health disorders can also very much so impact substance use. And as the brain becomes more frail over time, it will become more vulnerable to the effects of drugs. So a substance dose, whether that substance is crystal methamphetamine or alcohol or prescription hydromorphone, the same dose will have a disproportionately larger effect as the brain becomes more frail, whether that frailty is from multi-morbidity or from age. The frail brain has a difficult time with compensation, and substances really can reduce the ability for an individual to compensate. So somebody who's maybe just barely hanging on at home and starts drinking more because of the death of a loved one, they can very clearly decompensate. We know individuals exposed to lots of drug interactions that can be very difficult with substance use, and there's a lot of drug-drug interactions there. Neurotransmitter systems absolutely alter things. And then again, the medical comorbidities can absolutely affect drug absorption, distribution, metabolism, all of it. So this is just a bit of a question for you guys. This is a fairly recent change. Do you know the number of alcoholic drinks per week that is considered safe based on the most recent literature? I'll give you guys a little bit longer. And yeah, sorry, if you're not doing the Slido thing, please, feel free to pipe up in the chat there. So we have some 0, we have some 4, none. Thank you for participating. So the answer is 2. The newest Canadian safe drinking guidelines have shown that 2 alcoholic beverages per week or fewer results in no appreciable increase in morbidity or mortality that we can measure. Anything above that, there is a measurable increase in all-cause harms. So this is a pretty stark contrast from previous guidelines that were closer to the 8 to 10 plus range there. And really the purpose of this is not to say, oh my God, don't drink more than 2 drinks a week, but it's to start having a conversation about there's a risk benefit to start talking to individuals about after 2 drinks per week. So as we're going through this, I thought it would be useful to give a couple of examples of individuals here who we may have all seen similar things. Like, so the first off was an individual who is prescribed methadone. They also consume stimulants, and go figure, they have comorbid depression and they're prescribed citalopram. So that individual is exposed to multiple QT prolonging medications, and maybe they've been on that for a really long time and they've been stable on it. But again, as we just talked about, as they age, as their body becomes more frail, as the more comorbidities start stacking up, their metabolism changes, their CYP enzyme efficacy decreases, and all of a sudden, that individual who has had a stable dose of medications and a stable substance use disorder can start having significant QT issues with dangerous tachyarrhythmias or other arrhythmias. So a good example of how aging can result in significant issues even when our medications and substance use has remained stable over a period of time. The change in age and frailty can result in negative outcomes. Another person, for example, might come into long-term care and they consumed 3 glasses of wine a day at home before transitioning to long-term care. And as we just saw, that is higher than these safe Canadian drinking guidelines. So they move into long-term care for whatever reason, and several days in, they become confused. Now, it's pretty reasonable to consider that down to relocation delirium. Maybe their family members don't know that they're consuming 3 glasses of wine a day, or maybe we normalize it and say it's okay for grandma to be consuming 3 glasses of wine per day. That's fine. There's actually a really reasonable chance that that individual has an alcohol use disorder and they're actually experiencing alcohol withdrawal and not relocation delirium. So we need to have this in the back of our head as we see these individuals, and not just be screening them as they come into long-term care, but continue screening as we reassess them in their long-term care journey. So on that note, we third case, have a patient who moves into long-term care due to progressive decline at home. And they start using substances while they're in long-term care as a way of coping with that change. Maybe they lost a family member and now they're feeling more socially isolated, that they're in long-term care. And they were using substances when they came in, and they have been assumed to not be using substances while they're in long-term care, but they sure enough have. And so unfortunately, this individual hasn't been screened on an ongoing basis, and then they suffer repeated falls and other negative health consequences that are falsely attributed to other causes, when in fact they were due to somebody who was starting a new onset substance use disorder because of those major life changes that resulted in them coming into long-term care, but also being in long-term care is that major life change as well. So tying some of those things together, again, underdiagnosing high-risk drinking and normalizing alcohol again, we have new safe drinking guidelines, and we need to have a high index of suspicion as we continue moving forward about the dangers of alcohol and continuously screening people. Another major pitfall is assuming it's too late to change. So if someone's been smoking for 50 years, isn't the damage already done? And we know from really good literature that it's never too late to work on reducing substance use, whether that's smoking, alcohol, crack use. The impact on lung tissue or other end organ tissue really has not been fully manifested until they're dead. So, it's never too late to make a major change. Again, not continuing to screen for substance use disorders while in long-term care. Moving into long-term care is a major life event, but while people are in long-term care, they can become more socially isolated as their friends pass away, as their health declines. So we as providers in long-term care need to make sure that we continue to screen people, because new onset substance use disorder or escalation of low risk substance use can really escalate while in long-term care. And anytime you have a person that has a change in their status, we need to have a high index of suspicion in screening our patients. We also need to remember that there is a very significant link between psychiatric disorders and illicit or prescription drug use. So 20% of adults, older adults that is, with psychiatric disorders also have a substance use disorder or use substances. Patients with co-occurring psychiatric and physical health problems are at much greater risk of developing substance use disorders. That kind of loops back to what we were talking about, but also things like chronic pain, your vertebral compression fractures or your osteoarthritis. Those individuals, insomnia, are much more likely to start self-medicating. And physical health problems among frail adults can absolutely be worsened by substance use. And I'm thinking of, your hypertrophic cardiomyopathy or your alcoholic or stimulant-induced cardiomyopathies are a great example of that. So when we think of an assessment for substance use disorder, instead of certainly DSM-5 criteria is useful, but a larger, more holistic, comprehensive assessment tends to be more useful. And when we're assessing people for substance use in hospital, for example, we tend to more focus on something like this. So getting a full history of substance use and medication use. I've found people tend to be very open and honest with what they're using. Other providers might have a different experience, but I think as time goes on and we make a less judgmental and more normalized system that says it's okay for people to choose to use substances, and there's less judgment there, people are more likely to open up to us. So get a full substance use history and find out what medications they're on. Understand their medical comorbidities and psychiatric illnesses. Understanding their social circumstance and their family history. Do they have significant family history of substance use disorder? Do they come from poverty? Have they suffered or experienced homelessness recently? Getting a solid functional assessment to figure out where they're at, both physically and mentally. And with the mentally part is cognitive screening. We'll get into this a little bit later around capacity, but if, in your expert opinion, you guys all do long-term care, if somebody is not capable to make their medical decisions, they're likely not capable to direct their care around their substance consumption. Unfortunately for all of us, there isn't a nice cut and dry approach to this. So there's no consensus on the most appropriate or useful screening tools for older adults. The data just isn't out there. We do need to tailor the tools and our approach to older adults specifically, so we can't just take a standard approach and ask people about, their work and their school and all that kind of stuff. And we need to make sure, and again, I'm harping onto this, but it's really important that we continuously and routinely continue to screen for substance use, whether that's with new physical or mental health problems or major life events and changes. Screen, screen, screen. This is taken from opioid use disorder as an example, but it can really be translated to almost all substance use as a general idea about some of the major health areas or areas that can send up some red flags about a substance use. So, is a person wanting to cut down? Have they had health outcomes? Did they feel their substance use is excessive? Withdrawal symptoms. I'm not going to go through the whole slide, but this is a good general approach to, does this person have a substance use disorder, or at the very least, problematic substance use that could be causing negative health outcomes? And really, that's what we care about. We aren't too worried about finding specific diagnostic criteria, just is there problematic use that is causing that individual to have reduced health outcomes? We've spoken a little bit about this before, but this was just a good Royal College of Psychiatry snippet, just indicating that there are significant clinician barriers to screening and identifying substance use, specifically in the older adults, and whether that's failure to recognize it or discomfort with addressing it, or any number of different issues. And older adults do have barriers to admitting to substance use, and whether that's their stigma or there's shame, maybe their cognitive issues are there and they don't remember how much they've drank recently. There's multiple barriers that we just need to be aware of in screening for this. If there was, for alcohol specifically, one test that we would recommend, this is the test that seems to have the screening test, that seems to have the most evidence behind it, is the Short Michigan Alcohol Screening Test, geriatric specific. And scoring 2 or more responses of yes indicates an alcohol problem. So I'm not going to read through all 10 points, but if we had to choose one alcohol screening test for older individuals, this would probably be it. Unfortunately, just on that note, there's not validated screening tools for stimulants and opioids and all that. So at your discretion, consider using that test, but modified as you see fit for substance use in general. And just a reminder there that no screening tool outweighs your clinical expertise and your holistic approach, as we talked about in that comprehensive assessment. Again, trying to remember that we need to distinguish between a normal aging process that might have some polypharmacy there, and then there's addiction, and there's often a very challenging symptom overlap. So what's normal aging, what's polypharmacy, what's addiction? It's very difficult to parse out, and they often have the same phenotype, in that they might be neglecting their responsibilities, they might have problem caring for themselves, memory issues, etc. So that's where that comprehensive assessment, getting a collateral history and everything, is really important. We touched on this earlier about major life changes, but just really wanted to reiterate one of the major risk factors for either a new onset substance use disorder, really specifically alcohol, or an escalation in substance use, is loss of meaningful employment. So loss of meaningful employment really does create a huge social vacuum, a time vacuum, and people often have a reduced sense of purpose, well-being, and perceived happiness. So it really can lead to significant substance use. I know that's a little bit less relevant for a long-term care population, but just in the back of your heads. Warning signs that substance use might be a problem might include things like excessive or obsessive preoccupation with having enough pills or the timing of their dose, really like clock watching. If they become socially withdrawn, if there are unexplained injuries or repeated falls, that kind of stuff. Sleep disturbances, decline in functioning. And I think we can all appreciate that all of these things can very much manifest in other ways, whether it's natural aging processes, delirium, medical disturbances. So it is difficult, but these are some of the big things to look out for. So this next slide, I apologize, is a little bit busy, but I thought it was really important to go through some of the principles of care here. And this is paraphrased and very much shortened, even though it's so busy, from the most recent 2023 update to the opioid use disorder guidelines for the BC Centre for Substance Use. And even though it's from an opioid use disorder guideline, this very much captures not the medical approach that we need to have in our head, but the overall global approach we need to be thinking of. So I'm not going to go through all of this in detail, but we really do need to remember that patients' values, needs, how they define wellness is extremely important. We need to understand the context, the larger, grander social context where a patient comes from. As I mentioned at the very beginning of the talk, cultural safety for our Indigenous population is so important, and our anti-racism practices and trauma-informed practices cannot be overstated, the importance of those. We really need to make sure that we focus on patient-defined wellness, not have a paternalistic approach to substance use. Recovery is often not what people have as a goal. So we need to find out how we can reduce the harms of their substance use and treat them on a continuum of care. If somebody might need more extreme, I shouldn't say extreme, but more intensive therapy or monitoring at one point, they might at some point want to de-escalate their use. And we need to be very flexible in how we approach these people. It's a team-based approach, especially in long-term care. I did see a lot of nurses and other individuals introduce themselves in the chat. Thank you so much for being here. It is really important that we all work together and educate ourselves as a team about this. And if appropriate, as deemed by the patient, as long as they have capacity, it's really important to try and involve their social circle and their family. And part of that is destigmatizing substance use and letting them know that it's okay to talk about this, so we can all be part of shared decision-making and planning together. If we were to have a very brief set of goals in considering substance use disorder in long-term care, we want to reduce the physical illness that a patient experiences. We would want to increase their social engagement, and we would want to improve their psychological well-being. Please note in there is no abstinence. There is no forcing people into treatment and detox. Those are not our goals. Our goals are really patient-driven and patient-focused to improve their experience and the time that they have left. And a general approach to substance use, getting back to that circle diagram earlier, that comprehensive assessment is starting with a comprehensive assessment and screening, finding out what people are using, how much they're using, what their health outcomes are, what their cognition is, all of it. Often getting collateral history that cannot be understated in a long-term care scenario where there's often cognitive issues to begin with. So a patient might really underestimate how much they're drinking, and their family members are going to be very much a treasure trove of information. As we discussed, both from a drug-drug interaction point of view and also from a medical comorbidity issue with changes in metabolism, we really want to reduce polypharmacy. That's a given in long-term care, but it's even more important in individuals who consume substances. We need to have, as I've harped on about recently, shared decision-making between patients and us. What are their goals? How we can meet them where they're at instead of tell them where they need to get to. There are substance-specific treatments. We'll really briefly touch on that today, more just concepts and ideas, and we'll get into those in these substance-specific talks that we're going to get to. There are referral resources, and as I mentioned, we are all a big team here, and we really need a team-based care and education to understand that this population can be very difficult to manage at times. So we're not going to go into any of these today, but I know from overhearing conversations that I've had, there can be some anxiety around some of these topics specifically. So I just want to acknowledge that and just say that we are going to discuss these things in the substance-specific conversations we're going to have in the future. So IMAP, individualized managed alcohol program, so where people get to have dosed consumed alcohol as prescribed by a physician. Opiate agonist therapy, methadone's the classic one, but there's a wide variety of OAT these days, and we'll talk about it in the opioid talk. Safe supply, that's a really big topic right now, and how this applies to long-term care is very much an evolving conversation. Safe supply conversations are evolving as outpatient medicine, let alone when we start to consider the safety of other residents and cognitive issues, but we will talk about it. Everyone's favorite, motivational interviewing. It's still relevant in long-term care. It's still relevant in older individuals. So just bust out your motivational interviewing books and handouts and try and give yourselves a little brush up on it. We really won't be going too much into it, but it is still a validated tool in the elderly and the frail. Contingency management is something individuals have probably not heard of too much, but it is the only actual validated tool for individuals with stimulant use disorder so far. There's some burgeoning evidence about safe supply stimulants, but that's still controversial. There is zero evidence of that in an aging or frail population. We unfortunately have very little access to contingency management. We'll get into that in a stimulant-related talk, but I just wanted to acknowledge these entities exist, and we will talk about them in the future. Capacity, the big elephant in the room. So there's no easy answer here. The answer is it's really complex. It's a complicated scenario. Capable adults are allowed to make bad decisions, and we all need to remember that. We can all probably agree that choosing to use crystal meth is probably not the best for somebody's health, but as long as that person has capacity to make their health decisions, they can choose to do that. Assessing a person's ability to make those medical decisions is very difficult. So consider a consult, whether that is, and I know Dr. Blashko will say this is very difficult, and I agree, trying to get a psychiatric consult. Dr. Pawluk does geriatric addictions, so she can be a resource absolutely in this, and feel free to reach out to her through geriatric specialty services. I think I'll let Alicia comment on that. Yeah, it's complicated for sure. There have been times, speaking with friends and colleagues who do acute inpatient medicine, AMCS, where individuals have been admitted to hospital to be detoxed off of their substance, say alcohol, to get them to a point where we can assess their underlying cognition and determine that when they are free of substances, do they have capacity to make those decisions? That has happened. I don't think that's an answer for everybody. That would be a massive system resource utilization issue and very complex. But maybe sometimes assessing somebody first thing in the morning, so before they've had a drink. It can be difficult. They might be in withdrawal in the morning, but trying to find somebody before they have become intoxicated and having your capacity assessment done at that time can really be very useful. There are some tricks, and I'm sure Alicia has some more things to say about that, but yeah, that's all I really have to say about capacity. In terms of resources, so we're doing the series. Hey, thank you for showing up. We're going to do more. I've seen a couple of things in the chat about asking what some of the next steps are. It will be great to have you guys let us know what substances you want us to talk about. And even beyond that, is there anything specific that you want us to try and address? Do you have questions? We'll get to that in the chat afterwards. When we first started the talk, I know there was a plug for this, and I would like to do it again. So BC Center for Substance Use, they have two great programs. The Addictions, I just saw that I spelled that wrong, sorry. Addictions Care and Treatment Online Certificate is a Main Pro Plus CME accredited addictions certification that you can get. It goes through the most common types of substance use, including opioids, alcohol, nicotine, cannabinoid stimulants, the whole shabozzle, and gives you a good general overview for the physicians, and I hope, fingers crossed, nurse practitioners out there, I'm not sure, you can get paid to do it. They pay you fairly well. I think it's like $2,000 to do that program, and you get like 10 Main Pro Plus CME credits for it. So if you, in all the spare time that all of you have, I would highly recommend that. The Provincial Opioid Addiction Treatment Support Program, that's a mouthful, is the next step and is very much opioid specific. And it involves a couple of preceptorships in prescribing OAT, methadone, Suboxone, Cadian, Sublocade, which is the injectable 28-day Suboxone. That's a similar thing. Again, you can get paid the same amount of money. It's a similar amount of time, 10 or 12 hours or so, Main Pro Plus credits. So if anybody out there is interested in these things, I would really highly recommend these things. You get paid well to do CME that you need to do anyway, and it can help you with your practice. Okay, enough. I'm not paid by BCCSU, by the way. I have no conflicts of interest. I just think they're really useful, and I've done both of them. The race line is always good. I think the addictions medicine, you might not be able to get through phoning them. I'm not sure. I haven't called them myself, but there's an app that you can have on your phone and on your desktop computer. And you have to have a login for it, but you can connect with an addiction specialist and bounce ideas off of them. We do have Alicia, Pawluk, geriatric addictions consults. And then just one little plug, there is a PDF document put out by the College of Family Physicians of Canada. It's called The Practical Approach to Substance Use Disorders for the Family Physician. It is not a long-term care, frail, elderly specific resource, but it is a practical approach to substance use disorders for the family doc. So, you know, it is a bit of a one-stop shop. It's fairly superficial, but if you just need a quick PDF resource, that's, you know, there are worse places to go than that. It's probably my best one-liner kind of thing. And yeah, if we can give any future recommendations, what we would love to see as a group is we need to have increased awareness of substance use in frail adults. Again, thank you for being here. There are no tailored guidelines and recommendations for this. I would love to see that happen. Maybe with all the spare time I have with SPU and Chris Blashko and Alicia, we can try and work on that. Good luck to all of us for that. There are some age-specific services, or sorry, there are not many age-specific services for the treatment of substance uses. Alicia does her consults, but unfortunately, when it comes to, you know, that contingency management and other services, for example, there's no age-specific ones for the frail elderly. So we are underinformed, but also under-resourced, that's for sure. Okay, I've talked for like an hour. Time for questions, comments. Thank you for listening. And oh, also, I guess from Alicia and Chris, anything from you guys before we open it up to the floor? Chris.
Yeah, so I just want to again thank you for this very comprehensive review. You've touched on everything that I think we had talked about in preparing for this and more, and I think it's a good launching point, both to questions but also the series, because I think it creates a lot of questions for everybody, including myself. So I, again, want to thank you for doing all the hard work after our discussions.
No problem. And thanks.
Yeah, so I'm going to post a Slido link again. If you want to upvote the questions that you want us to answer, hopefully we can get to all of them, but this way we can kind of crowdsource the ones that are the most exciting. We'll kind of just go through, I think we'll take the Slido ones first because there's a good number of questions. And then I know there's a couple in the chat. And if I'll take most of the questions, but I'd love if either of the Chris's jump in at any point. Okay, so we'll just go in order of the most popular. The first one is, please suggest strategies for convincing long-term care residents to stop or reduce substance use, such as cannabis, alcohol, nicotine. The best tool for that is motivational interviewing, finding out where the patient is in terms of the stage of change model, what's their goal, maybe what risks and benefits they get from using substances. So just thinking about, yeah, motivational interviewing is really the biggest thing. And then also, if the patient is not in the place where they want to stop or reduce substances, then we kind of have to meet them there too. A second question is,
Alicia, can I just add one part to that question? And it's something I've been learning is spending some time at the long-term care sites is each site has an MRP or a small group of physicians that are deeply involved with the care of people over a longitudinal period of time. And the one thing that I believe sometimes gets intimidating is things like, okay, what is motivational interview? I don't have skills, but these are skills we all have as physicians. We're trained to participate in engaging, convincing, educating people. And more importantly than any specific question we ask, it's our relationship with our clients. So saying hi to them, engaging with them, making comments about what's going well, asking about their family. These are all segues into the conversation of change. It doesn't always have to be structured, formal, but with the principles of motivational interviewing are really important. But the truth is having a good, solid relationship with your clients. And I've always been impressed watching MRPs in these settings, how they really get to know people. And that goes a long way for initiating one change and willingness to sort of make a movement forward in their condition, whatever it might be. So I just want to highlight, we don't have to necessarily have a whole lot of training, but that relationship we have with the clients in these settings over a long time is powerful, powerful work.
Exactly, yeah. And I do see there's a question about a good skills course. I don't have that answer unless Chris knows off the top of his head. But we can add that into a future presentation because that's one of the treatment or options that we use. All right, next question. This next question is a very weighty question. So I'm going to kind of give a bit of a evasive answer. So I just want to preface that. The question is unclear what is meant by oppressive colonial system. Can you share which aspects of LTC is oppressive and colonial and how can we address these? That is such a big question and it is incredibly important. I actually think we should put this into a future presentation specifically. The recommendations by the Truth and Reconciliation Committee, there are actually quite a few island health documents that talk about how we can reduce and be actively anti-racist. So there are actually some documents that specifically address this, and we'll see if we can find them and then share them. But I feel like this is an answer that deserves a thorough response. I don't know if either of the Chris want to chime in on that. No. Okay.
Yeah, I'll chime in on that. One thing I will say about that, and I agree with Alicia, this is a very big, weighty topic and conversation, but something that just came up today, for example, is about individuals who are brought down to Victoria to, say, the Summit long-term care facility, for example, because it's an owned and operated by Island Health facility, because they have substance use or psychiatric disorders that are not able to be managed in their hometown. So there are several people on my unit, for example, but not just my unit, on other units that are from Campbell River, they're from Comox, they're from other areas. Sometimes these people are Indigenous, and we have denied them service in their hometown because we can't support them. And we have relocated them to a facility in a new city away from their supports, and told them that they have to live here. I don't know if any of you think that that sounds fairly familiar, but that is terrifying to me that we are doing that. That is colonialism. These people who may have gone through residential school system that have been exposed to power dynamics and hierarchies are, again, in a system that is not necessarily compatible with their culture, and they're in a power dynamic that they are again, like, removed from their supports from. So way too big of a topic to kind of get into here, but there are many, many, many examples of how this is a very problematic system for many of our patients. So I'll just leave it at that.
That was a great answer. So yeah, there's lots of things. Well, we actually will get into this because I think it's important. The next question I have is how to manage acute pain in residents on OAT. So the next most important thing would be using your pain adjuncts, the WHO pain ladder, if you're not already using those. And then just expecting that if you are at the stage where you're using opioids, that the doses will be higher. You may need to, for example, if they're on methadone and you're trying to treat pain, sometimes it's more effective to split the dose. So just thinking about how we can kind of manage their pain and not being afraid to use doses that we might not consider for someone else who's not on OAT, because if someone's on 250 milligrams of methadone a day, their tolerance is going to be a lot higher than most people.
I just see somebody has their hand up. Faria Ali, you have your hand up, and just wondering if you wanted to comment on something there. And my apologies if I have mispronounced your name. No, okay, maybe not. Fire something off into the chat if you would like to. Oh, no, yeah, hands down. Okay. Oh, it was by accident. Okay, thanks. Appreciate it. Bye.
I'm also very guilty of hitting that button accidentally too, so I feel you. The next one we come to is, this is a question I get a lot. Substance users also seek other meds such as Gravel, Tylenol, which are often standing orders. Any suggestions? Yeah, comes back to, again, motivational interviewing. What need are we not meeting? So is this an underlying psychological need we're not meeting? Are we not meeting a like social contact need? I think identifying the actual problem behind why they're requesting these, and certainly Tylenol not as much, but Gravel, Benadryl, I see often really frequently, like, used to treat insomnia, but the patient's saying that they're feeling sick every night before bedtime. So we need to just clarify, is this actually a medical issue that we need to be worried about? And if not, then what actually is the underlying issue? But yeah, that is actually quite common. Because I see you're unmuted. Okay. All right. Okay, the list is kind of changing as we go. Patient competent with daily alcohol use their whole life, no desire to quit. Are you suggesting that is fine in long-term care? Yeah, so if the patient is competent and they are not harming others or themselves, then that is something that we need to support in terms of their autonomy to make that decision. If they're harming themselves or others or are not competent, then of course we need to talk about how we can minimize risks or discuss those. But really long-term care becomes people's home, right? And so it's, like restricting people's in their own home. And so it's challenging, and as we pointed out, it's not necessarily within the safe guidelines. But people choose to do things in long-term care all the time that are unsafe, you know, leaving their walkers behind and they're halfway down the hallway, that sort of stuff. And so just kind of going back to, you know, how can we make them comfortable and safe in their own homes? All right. Circling back to the assessment, to ability to make medical decisions, do you recommend any go-to assessments, whether standardized or non-standardized? I don't actually know. Chris, do you know that answer?
There's really only one validated assessment called the MACCAT, or the MacArthur Assessment of Capacity to Make Treatment Decisions. That requires a lot of reading and training. However, the authors of that document, there's a lot of good basic information that you can research. So for example, there's a 2016 article in Archives of Journals of Neuropsychology, the Assessment of Healthcare Decision-Making Capacity. If you search out that in PubMed, you're going to find a lot. They are all based on essentially a few simple questions that you have to answer through your assessment. Does the patient understand? Do they have the information to understand? Can they appreciate the impact of that decision or choice or whatever they're doing on themselves and their immediate surroundings? And are they able to exercise that choice and accept, and not necessarily accept the consequences, but they understand that there are consequences to those decisions. So it's understanding, you know, they have information, they understand, they can weigh out the pros and cons, they can appreciate or rationalize their choice and how it relates to them, and then exercise or express a choice. That's the fundamentals of capacity assessment. For each, and the other thing about capacity assessment, it is dependent on each decision. So if somebody, they can have medical capacity to make choices about minor topics, like, you know, they need a basal cell carcinoma removed. They understand it's cancer. They want it taken care of. However, they may not be able to appreciate that if they're drinking 10 to 14 alcoholic beverages per day, that their walking's getting worse, they're falling and soiling themselves. And that's also why they're refusing to get basic care. They may not appreciate the impact of giving $40 to, these are stories from the summit, by the way, at the SPU, $40 to one of the other individuals who's more mobile to go across the street and buy liquor. They get the $10 liquor and they lose $30 or extorted $30 by this other person. So that now is an issue around financial capacity. So I think we need to be very thoughtful. And as we're approaching it, what I recommend is, what is the question that we're actually evaluating here in terms of capacity? Try and craft those questions to the patient. Also get information from the team that you're working with, and collateral information so we can fill out the entire understanding of that particular question, and then make a decision, and then go through the process of how to enforce that decision if the person is in fact incapable. One of the most powerful tools that we've had for a few people who are on managed alcohol, who were drinking on top of their managed alcohol and deteriorating, was actually controlling their money. And having a system, and it's a tough process, particularly I think our social workers and frontline staff really, I am thoroughly impressed how they work with these folks and create plans, but it is tough. That actually really can change outcomes when we can maybe get the person on a managed alcohol schedule, but take away other sources of alcohol or harms because their finances are a problem. So identify the question, go through that process, get all the collateral. Cognitive assessment may be relevant, but a number does not tell whether somebody's actually capable or not. I've seen people with MOCAs at 12 who actually understand a lot more than we think they do. So it is a complex process. And if in doubt, if you have access to somebody who's doing this on a regular basis, like psychiatry, ask them. If you're not sure, make a phone call, and then we can walk through the process. So that's a bit of a long-winded answer to this complex question, but there's lots of really good literature out there about this topic.
Thanks, Chris. Yeah, this is probably the most common reason I get consulted is, does this patient have the ability to make this decision to continue to use substances? So yeah, really relevant question. I'm going to group a couple of the questions together because I know we're coming towards the end. There's a question about, do we ever stop Cadian? And there's a question about stopping naltrexone in a patient who is no longer drinking and stable. So the initial evaluation is are they still at risk of harm? Is their goal, being met in terms of their substance use? And, are they at risk for developing or increasing their substance use if that's not what they want? So if a patient's on Cadian and they're frequently going outside to use substances, there is lots of literature that says if you stop their Cadian, you're basically going to increase their mortality by a significant amount. If the person does not have access to substances or is feeling like their substance use is controlled, that again, that's a discussion between you and the patient as to like how you're going to monitor that, and tapering, in a slow way. If the patient wants to continue it and there's no other consequences or it's not interacting with other things, then generally like the default is to continue. Same with naltrexone. Again, obviously there are more interactions with naltrexone, including pain management, but if someone is feeling like they're no longer at risk, that being said, I generally give them a good few months. I have a lot of patients that go on naltrexone, stop drinking, and want to come off of it 2 weeks later. The evidence base is that it is like they're used as they change your neurotransmitters, and so just like an antidepressant, if someone's feeling great 3 weeks after you start it, you don't stop it. And so kind of giving them a bit of time to adjust to it. The next question is gabapentin addictive or not suggested for patients with substance use disorders? Yeah, we actively use gabapentin for management of substance use disorders. So specifically alcohol, it's not first line, but it is something that we use. That being said, gabapentin does have addictive properties, and we do have people who have gabapentin use disorders. So it is, and in older and frail people, there's quite a few side effects, including cognitive falls, that sort of thing that are attributed to gabapentin. So it can be used. It's a useful pain adjunct. It's a useful adjunct in the use of alcohol management. There's some, potential benefit that in alcohol use disorder, it also helps with the seizure threshold. But again, like not in a meaningful sort of numbers way. And
sorry, I just wanted to weigh in briefly there on the previous question about stopping Cadian and naltrexone too. I don't know how much evidence or data there is around this, but one thing that I was taught by one of my mentors in residency, one of the OG doctors back in Halifax, was substance use and substance dependency is a complex neurophysiological process, and withdrawing is a complex neurophysiological process, but so is abstinence, and it takes time. It takes a long time, especially in a frail and complicated brain. His go-to statement when he was speaking with people, when they were saying, how long do I need to be on this methadone? He said, how long were you on your substance for? And they said 20 years. He's like, cool. You'll probably need to be on this for 20 years. And his go-to was as many years as you were consuming an unregulated substance and having some chaos and having disrupted neurotransmission in your brain is probably about as many years as you need to create stability in your dysfunctional, dysregulated brain. Now, again, from what Alicia was saying, if there are other negative health outcomes, if people are falling because of polypharmacy and all that, that would change the picture, but just in a general term. Chris.
Yeah, just to add to this, substance, I think also needs to be viewed as a chronic disease process. That's so I like what's helped me sort of get more accepting of this over the years, because I was trained in a period of time where shooting for abstinence was our goal. Opiate use disorder, you detox a person for 3 days, then they're better, which we know is wrong. So what helped me understand this was the analogy of type 2 diabetes associated with obesity and poor health habits. If somebody is struggling to improve that, we still treat them with medications. They get on glyburide, metformin. We give them education, nutritional counseling, and an ongoing process. But and we're more accepting of obesity being a chronic disease kind of process. And I think addictions, like many other mental health related phenomenon, are chronic. There's a point where some people, and a small percentage, have tremendous success with abstinence. But talking to enough people with alcohol use disorder, they always talk about it. I'm an alcoholic. I will always be an alcoholic, but I haven't drank in 30 years. So they're at risk, they're vulnerable, and they're working the program constantly. Maybe that person, we need to help people get to that level of abstinence in some circumstances. But that's, in this population, if they're established with a substance in long-term care, and we're trying to help them manage it, we're about reducing harm risk. So it's like, again, providing metformin for the sugar control to decrease potential harm risk. So that's how I've found it more sort of acceptable and actually more compassionate to think about these problems from that lens.
Thanks, Chris. And we all know those patients that, you're like, oh, you have any medical conditions? They say no. And you're like, but you're on metformin. They're like, oh, well, my sugars are good. And you're like, okay, well, that's so things we need to consider. There's a couple just med questions, which should be pretty quick. How long does it take for the QTC to be affected by medications? I'm going to answer this with my acute care hat on. It can be relatively immediate, like as soon as it is absorbed into the system. It's also dose and accumulation dependent in some medications. So you might not see it with the first few doses. After, a month, it might start to build up, but it can be pretty quick, and also dependent on which other medications they have, which can prolong QTC. There's a QTC checker that actually, if you Google that, you can put different meds in, and UpToDate will also do that for you in Lexicon. So we can check that. High burden of substances, including prescription medication, can have a negative effect on HIV control. I don't know the answer to that question. Chris, do you guys know the answer?
Sorry, what was that again?
Does the a high burden of substances, including prescription, have a negative impact on HIV control? I guess we're assuming this person is not continuing to be exposed to an unregulated supply in which they might be exposed to other bloodborne viruses.
Not sure.
Yeah, we can find out the answer and come back. The alcohol screening test is SMASH-G, the short Michigan alcohol screening test geriatric. Don't quote me on that, but I think that's what the acronym stands for.
Oh, can I, I'll circle back to that question. I'm reading it more, a little bit in regards to high burden of substances. What we do know is that treating substance use disorder improves HIV control. So certainly high levels of substance use will increase the risk somebody will have HIV. That's a huge harm reduction goal for opiate use treatment and harm reduction. So I'm not sure if that actually answers this question, but I think if we acknowledge, treat, and address this from particularly a harm reduction point of view, we're going to reduce the risk for folks with HIV or at risk of acquiring HIV.
Yeah, I do want to weigh in that. So there is some evidence that fentanyl specifically will reduce the plasma concentrations of some and mostly older HIV medications, specifically, I believe, protease inhibitors and one other, and I don't remember exactly what it is, but fentanyl does reduce plasma concentrations of that. So I don't know if it's burden of substance use, but certainly there is a medication drug interaction, which again kind of goes back to part of the talk of there are drug interactions with substances. And so, yeah, that is the one that I know with fentanyl. But if people are on modern single tablet HIV regimens, such as Biktarvy, I know specifically for Biktarvy, for example, there isn't any drug interactions, but.
Thanks. Couple last questions. Someone just asked about can the MAC-CAT TB administered by health clinicians. Chris Blashko has actually put the answer to that in the chat on Zoom if you want to take a quick look. We have a question about a patient who's reporting erectile dysfunction for 3 months. May that be a motivator, and how long would it take to see if that's reduced intake would help? That's a great question. I don't actually know what the dose response curve for alcohol and erectile dysfunction looks like. Certainly there is a causation between alcohol use disorder, drinking alcohol, being intoxicated, and erectile dysfunction. I think that's pretty strong in the literature, but how long that would take to see a reversal, some people would say like as soon as they stop drinking. Some people say it takes like a couple months. Same with opioid use disorder.
There's just a really quick one here in the chat that I just wanted to address because it came up in a meeting today with Ireland Health executives. Is there a change in people using because the people around them in care are also using, and is having people together with substance use issues showing improvement in outcomes? So complicated answer. Yes and yes. It seems to be the answer there. So from the specialized populations unit, for example, certainly there are people who are there who are vulnerable and do not use substances or have less access to substances. And as Chris pointed out previously, maybe there are people that are more mobile and able to get them substances. I'm thinking of one specifically who a very dependent personality disorder kind of individual, but who is very limited in terms of her mobility, but she will take crack cocaine and buy crack and meth from other people who are more mobile. And of course, that really deteriorates her health and her mental health. So there are people who are using because people either are using around them, or if they're given a chance, they will use, but they might not be able to elsewhere. And yet at the same time, we seem to have some at least emerging trends that there are some improvements in outcomes when people are housed together in terms of their seems. So from a specialized populations unit, for example, our nurses and our care aides are trained in substance specific issues and the mental health issues that are related to that. So I think the benefit is from the care team that are more experienced, but certainly ghettoization of individuals in long-term care who use substances is not the answer. So yeah, sorry.
Yeah, I would echo what Chris is saying. This is a complex, emerging, political, ethical, and sort of issue. And I think data-wise, there's no data. I can pretty comfortably say we don't have any data for individuals who have pre-existing disorders. If you can provide a robust system of care, you're going to have better outcomes. Or at least maybe not in the way we think of better outcomes, such as living longer, maybe having less morbidity, but maybe maintaining dignity could be a good outcome for folks. I think we'll have this data in the next few years. We're going to start looking at what's happening at SPU, for example, which is a cohorted population of people who have a mix of mental health, brain injury, and substance use disorders. We're going to see what this actually means. I would actually suggest that will be a separate talk. It'll be interesting down the road. And part of the bigger picture look at this, because in the future, it's likely most new builds for long-term care are going to have SPU type units. It's just that important. But since we're at the end, I just want to thank Chris and Alicia as our presenters and everybody attending. This is really pretty remarkable, the attendance. I can't believe that there's 85 people who signed in or something like that. It's pretty remarkable. So it really shows the importance, and have a great evening.
Thank you, everyone.
We will stick around to answer the few last questions. So if people are super keen and your question wasn't answered, I'll quickly address those. So if you want to stick around, we will answer them in a later talk too. So I'll just see if like anybody's going to hang out for those questions. Thank you all for coming. Okay, well, we'll jump to just the last few questions just so people feel like they've had an equitable answer. And I'm going to cut the questions off now. There's just, it sounds like a comment, patient loses capacity when drinking regularly, they put in long-term care against their will, regain capacity, leave, and then start drinking again. Yeah, I see all or most of those patients. It also happens in hospital. Again, comes back to the issue of capacity, which I think we should touch on, and probably during the alcohol talk, we'll get into that. And in a patient on Suboxone experiencing acute pain, how do we address the risk to overdose while on Dilaudid during this acute pain episode? Ensuring that their pain is well controlled with Dilaudid, and finding out how their substance use has been affected by their acute pain, which will probably be increased. So figuring out what sort of safety measures you're able to put in place, and also just making sure their pain is adequately controlled, right? It's very challenging. Dilaudid is like, or Suboxone is like having a life vest on. It helps you most of the time, but doesn't help you if like the entire boat is sinking. So, and also not taking people off Suboxone. I think I should be clear on that one as well. I think that was the end of the questions that at least I have. If anybody else has anything else, we can pop it in the chat, or we will see you at the next one.
There's somebody who said, in terms of folks drinking, use of CWA and offering alcohol and Ativan as harm reduction. Yeah, so I mean, offering alcohol as harm reduction, so that's IMAP, the Individualized Managed Alcohol Program. So we'll get into that in the alcohol specific talk. But yeah, if your facility supports IMAP, that's great. And then what else? Oh, in terms of using CWA, yeah, I'm not sure from a long-term care perspective if we tend to use CWA. It's very nursing intensive. It's especially initially, it's like an every 1 hour assessment. So I could imagine that it would be difficult to have the nursing acuity to be able to do a proper CWA. Ativan is harm reduction. Again, we can get into this with the alcohol talk. Usually diazepam would be used. I know Ativan's technically, part of the older order set, but yeah, usually I tend to use diazepam even in older folks. Well, okay, Alicia is kind of giving me a shrug there. Okay, maybe not. I let her kind of weigh in on that one, but yeah.
Yeah, again, CWA like quite intensive. If you think someone's at risk for actual alcohol withdrawal, and especially if they have any history of delirium tremens or seizures, the patient should be in a supervised medical unit for that. It is a very dangerous thing for someone to withdraw from alcohol unsupervised. And there is actually a death or maternal mortality rate associated with that. So making sure patients are adequately supported if you're really worried. And if you're not really worried, then, making sure you are keeping a closer eye on them. You can use CWA as a guideline. And I generally use lorazepam, but just there's a few pharmacokinetic things we can get into in terms of alcohol and CWA in the next lecture or next talk.
Awesome. Okay. Thanks everyone. Really appreciate it. Thank you to Chris and Alicia. You guys have been awesome for a lot of the questions there. And yeah, for the remaining 20 or so people, thanks for sticking around. We'll see you guys later.
Thank you so much. Everyone have a great night.